Good evening, everyone, and thank you for joining this evening's program, the Triple DMEK Pearls and Pitfalls. My name is Michelle Galazewski, and I'm a Partner Relations Director with Eversight. On behalf of all the staff at Eversight, we are so excited to have you with us tonight. In an effort to eliminate all background noise, all participants will be muted throughout the duration of the webinar. If you would like to ask a question, you may do so by typing your question into the Q&A panel at the bottom of your screen. We will address all questions at the end of the webinar. At this time, I would like to introduce our speaker for this evening, Dr. Parag Majmudar. Dr. Majmudar is a fellowship-trained corneal and refractive surgery specialist and a practicing physician at Chicago Cornea Consultants. Dr. Majmudar is an active participant in clinical research activities and is a highly regarded lecturer and instructor on the subjects of corneal and refractive surgery. He serves as an Associate Professor of Ophthalmology and formerly co-directed the Cornea Fellowship at Rush University in Chicago. Dr. Majmudar is an active member of the American Society of Cataract and Refractive Surgery, as well as the American Academy of Ophthalmology, and he recently received the Academy's Senior Achievement Award. He is an International Council representative from the United States for the International Society of Refractive Surgery. Dr. Majmudar, you can begin.
Thank you very much, Michelle, and thank you to all for logging in and listening to the presentation tonight that is sponsored by Eversight. And today we're going to be talking about the DMEK triple procedure. Prior webinars that Eversight has put on have highlighted the DMEK procedure specifically, things like patient selection, as well as surgical kind of tips and techniques, and we can kind of cover some of those as well. But today they've asked me to talk about a concept that sometimes there's a little bit of uncertainty in terms of how to proceed. And that's when we have to combine DMEK surgery with cataract surgery. And so I am going to talk for the next about half hour or so. We'll give you some ideas, tips, pearls. I'm going to go through a basically unedited video of a procedure, and I can highlight some areas where I think it might be helpful to make the transition from doing purely DMEK to doing DMEK plus cataract surgery. All right, now let me see here. Okay, so one of the first things that I learned in medical school, and this kind of came back to me very recently because my daughter just started medical school about a month ago, and this is one of the revelations that I had when I was very young, and it was something that I didn't expect in healthcare, in medicine specifically. But all of you who are in medicine know that really nothing is black and white, and there are a lot of various gray areas. And this is a quote that I remember hearing about from Dr. William Osler, who's one of the pioneers in modern medicine, one of the founders of Johns Hopkins University. And this quote always struck me as a little bit funny and interesting and actually true. And that is that medicine really is a science of uncertainty, and it's an art of probability. And I think that's why you might find that a lot of ophthalmologists specifically have some artistic talent, and there is something to be said for having a science as well as a combination of science and art. And really, it's not any different when we're talking about a situation that we face a lot in clinic. Fuchs, corneal dystrophy, and cataract, and coexisting disease. Obviously, we're dealing with elderly patients, so cataract is definitely something that's going to be much more common in this patient population. And then when we're talking about the subset of patients who had Fuchs, now we see that there may be a lot of overlap between these two conditions. And I was asked to give this talk maybe about a month ago, and so I was kind of thinking about what I would say. And I really found that as I'm going just through my normal day, I could see examples of patients with both Fuchs and cataracts where I had to go through this sort of algorithm or flow chart in my mind to kind of come up with a best approach for the patient. As we know, years ago, when someone had Fuchs plus cataract, we would delay the corneal transplant until it was absolutely necessary. And that was because the corneal transplant procedure from the 1990s and 2000s was fraught with significantly prolonged visual recovery, uncontrollable astigmatism, and it was something that we don't like to look back on, but we're so happy that we have modern techniques like lamellar surgery like DMEK and DSEK that have accelerated patient recovery time. And now, because of that, we don't need to wait for severe deficits in visual acuity and visual functioning. Similar to what the evolution has been with cataract surgery, we don't no longer wait for someone to have, hand motion cataract before we'll operate on their eye. And that's due to technology. And so we now have we're put in a situation where we're going to be faced with these types of patients where they have concomitant Fuchs dystrophy and cataract. And so when is it appropriate to perform a combined DMEK plus a cataract surgery? And more importantly, when is it best for the patient? So obviously there are a lot of gray areas as we mentioned. When we combine cataract surgery along with DMEK, and that's the so-called DMEK triple procedure, there's a lot of advantages. Patients have one surgery, they don't have to come back twice. And there have been recent studies now, one paper that was published in 2014 in ophthalmology from the Price Vision Group, where they showed that there was equivalent visual outcomes, whether the patients were having combined triple surgery versus DMEK alone, and then cataract subsequently. Price also found that there was no increase in complications when doing a combined surgery, and there was no difference in endothelial cell loss. Another advantage of combining the two procedures is that you avoid the inevitable cataract formation. So if you have a youngish patient, who has, let's say 50, I just turned 50 a year ago, so I feel like I'm pretty young. But let's say a patient who is not quite ready for cataract surgery, but they do have significant guttae and visual dysfunction from Fuchs dystrophy, those patients who have DMEK are often going to have an increased progression of cataract, generally faster than they might otherwise have expected. And this is common with a lot of different intraocular surgeries that we can perform. They can stimulate the progression of cataract. And so there was another study also that Price and his group found that 76% of patients had cataract progression, and 33% of those underwent cataract surgery within the first year after DMEK. And so this is something that needs to be discussed with patients when you're talking to them, when you're sitting in the chair and saying, hey, look, you have no cataract, but we're going to do DMEK, and there's a good chance that I don't know if it's going to be a year or 2 or 3, but probably earlier than you would have otherwise needed, you may need cataract surgery. So what are the disadvantages of combining? Well, there are a couple. The biggest thing that we found when we first started doing cataract surgery with DMEK, and this is going almost 8-9 years ago that I started doing this, is that there were some refractive surprises. And we would find that I would pick a lens implant for someone to be emmetropic after cataract and combined DMEK, and they would end up +1 or +75. And that's now, I think it's well understood. But this shift of a half to 1 diopter is something that we kind of now expect, and we compensate for that when we're calculating our endpoints. And another study that Price and his group published, or actually presented in 2018 at the AAO meeting, was that when you have a combined procedure versus DMEK alone, there's definitely less refractive accuracy. So patients who had DMEK and then cataract surgery had a higher percentage of patients who were 20/25, 65% versus 39% when you just did it all in one sitting. And 97% were 20/40 when you did sequential DMEK and then cataract surgery, compared to patients who had 80% 20/40 or better with combined surgery. And so this is something that is not difficult to overcome, but you certainly need to be aware of that as a cataract and DMEK surgeon. Another disadvantage, of course, of cataract surgery is that most of the patients who are on the younger side are going to have a significant loss of accommodation. Now, if they have a cataract, I don't think you can avoid it. And I think you have to accept that this is one of the complications or side effects, if you will, of cataract surgery. But in that situation that you're doing the procedure for someone who has a cataract, you're obviously improving their visual acuity. And at that point, that certainly takes precedence. The issue becomes when you have a patient who is on the younger side and you're kind of in a gray area again, as to whether or not to remove the lens. I think it's important, again, to bring up this concept of loss of accommodation when you remove a lens. We have made some progress with multifocal or EDOF lenses, but up to date, I have not really been really anxious to put in any of these types of lenses in patients with Fuchs dystrophy or in patients who are having DMEK, because I think there is still some potential for a surprise in terms of the astigmatism or astigmatic result after DMEK. There may be some issues of loss of contrast sensitivity. And I don't think it's well enough studied yet that I'd feel comfortable putting in an EDOF or multifocal lens in a patient that is going to have DMEK or has had DMEK. The other downside of doing cataract surgery at the time, and I tell my fellows the same thing, is that when you're starting out in your practice, maybe don't pick a combined case for your first few. Let's get comfortable with DMEK. Let's get comfortable in knowing how the anterior chamber behaves, how that iris and IOL diaphragm behaves during the DMEK maneuvers or the DMEK dance and trying to get the graft to unfold. Because there's a lot of nuances there that you're just learning when you're starting out. And so once you've mastered those, then I think you can tackle doing a combined procedure, because there's no doubt there is definitely more instability of the anterior chamber. The iris and IOL diaphragm is much more trampolining that you get when you're trying to make your maneuvers. And so I think that's something that has to be taken into consideration. As you get more comfortable with both procedures and combining them, of course, I think that this doesn't become as big of an issue, but certainly in the early learning curve, I think this is something to do or to take note of. So how do you best decide on the course of action, right? So there's basically three possible scenarios that you can kind of come up with. So you might want to consider doing the cataract alone. And this is something that I would kind of think of as parameters to decide whether I'm going to do cataract alone in a patient with Fuchs dystrophy. Obviously, if they have very mild Fuchs dystrophy, their central corneal thickness is less than 600. They have just mild scattered guttae clinically or on specular, and they're not complaining of some of the typical symptoms that patients have when they have Fuchs dystrophy, things like blurred vision earlier in the morning that gets better later in the day, or glare, which now when they complain of glare, it could be from cataract as well, so you have to kind of tease that out. But those are the simple cases where, okay, look, your cornea is not that bad, I'm just going to do the cataract. I think you have to make sure that you explain to patients that when you do cataract alone, the DMEK may be necessitated earlier. Corneas may decompensate. And so that's something to discuss with patients in advance. The other reason to sort of do cataract alone, and I see this from time to time, and I just had a case of this a few maybe weeks ago, where there was a patient who lived alone, and they would have had a very, very difficult time kind of navigating through the DMEK recovery based on their age or based on their social situation or whatever it was. And so we made the decision to just do the cataract alone, even though the cornea was sort of a little bit more on the borderline. And we said, well, let's just get the cataract done. Let's see how much vision improvement occurs, see if they can function a little bit better, and then you can go, forward. There's also a potential situation you can imagine that, let's say there's a monocular patient. A patient has had loss of vision in one eye where they can't function, but the eye that's the good eye now has mild to moderate Fuchs, and they have also a cataract. If you think that the cataract is a little bit more prominent, at least in terms of the percentage of involvement in their vision, then I think you can definitely decide to do the cataract alone and see whether or not, if you do careful cataract surgery and monitor your phaco energy and make sure you're kind of not phacoing in the anterior chamber, you can probably get away with cataract surgery alone and allow the patient to sort of make a little quicker recovery and get back to normal activities where they may not need the DMEK. Now, when we have that situation, of course, we have to kind of think about the overall situation, not just central corneal thickness or specular microscopy or cell counts. Think about the patient's overall situation and ask them about kind of what their social situation is and how do they have help and can they function with their other eye, for example. If you do DMEK on a patient that's monocular, we do it. You have to warn them that they're going to have, maybe a week or two or three, whatever the case may be, before they can kind of see well and start to function. So I think that's really a significant consideration. So there's the opposite situation where a patient really doesn't have cataract. and you don't want to have them, lose accommodation. They may be young, they may be in their 40s. Let's say patients have significant fuchs dystrophy at age 45. Well, in that case, you're definitely not going to recommend cataract surgery for the reasons we mentioned. And so that would be a reason to do DMEK alone. Another reason to do DMEK alone is this happens from time to time as well. The patient may have advanced corneal edema. They have had longstanding, fuchs dystrophy. They haven't done anything about it. And for visualizing that cataract might be very, very difficult, at least safely, getting the cataract out. So in that situation, you may want to counsel the patient that they might have to have the DMEK first and then do cataract surgery once you've got a much more clear view. And again, there is a little bit better refractive accuracy when you do it that way. And so most patients, if you kind of give them the understanding or the explanation as to how you're coming up with these ideas, that's what I would certainly urge you all to sort of have a good discussion with your patients about all of these factors. And the final sort of decision flow chart would be when to do the triple surgery, the triple procedure where you're doing DMEK, cataract surgery, and intraocular lens insertion. So obviously, if your patient has significant cataract and if you've left that behind, it would not improve the visual acuity for their activities of daily living. I think it makes sense to do cataract at the time of DMEK. If a patient is a little bit older, I would say if they're 65 plus, I'm not sure that I'd probably recommend doing DMEK alone, as long as there's no cataract. I mean, if there's a mild to moderate to severe cataract, I would err on the side of doing a DMEK triple procedure, again, to save the patient not only multiple surgeries, but also to get them the best chance to be able to see well after the intervention. If a patient has significant fuchs dystrophy, then of course I think you're going to want to do both together. And again, on the flip side, if they've got, as I said, just a significant cataract and they have moderate to severe central guttae, which if you did not do anything about, they would end up having more difficulty, then I think that's another indication for doing combined procedure. So I just threw a couple cases that I've come across over the last few weeks, months, years, whatever, and kind of gives you a highlight of some things where you may or may not approach it the same way I did, but I think gives you something to think about. So I have a patient who's 48 years old and he has a family history of fuchs. His father's undergone PKP in the past, and now he's starting to complain of glare. And if you look at his slit lamp exam, you can see that his exam is, the visual acuity is 20/30, 20/25. If you do glare testing, he does, have moderate to severe glare, especially in that right eye. And he has some confluent guttae that are extending outside that central, 5 millimeter zone. But when you look at his lens, as a 48-year-old, you're not going to see a significant amount of cataract. So I think here it's not too far-fetched to say that all of us would probably just do DMEK alone. We want to preserve accommodation. You have to warn the patient that cataract formation may occur more rapidly than if you didn't do the DMEK at all, I guess. And as I said, when I first started doing DMEK surgery in 2012 or 2013, I did this in a few cases where, at that time it was sort of the trend was that, oh, you know what, you got to do them both together. You got to take out the cataract. They're going to get significant cataract. Now, I will tell you that the Price study did show that a significant number of patients did get cataract within the first year. But I think our technologies evolved, our techniques have evolved, and I think our management of the air bubble or the gas bubble has evolved. And I think that you can probably get by, and it's not such a automatic thing that they're going to get cataract. I do have some patients from 7, 8, 9 years ago that they were in their 40s, maybe early 50s, and I did not do cataract. And at that point, I was telling them every year, hey, you're gonna get cataract, you're gonna get cataract. And they're still like, hey, doc, I'm seeing great. I don't have any issues. Do I have a cataract? And some of them started to develop a little bit of changes, but nothing where it was, blown up within a year and they needed surgery. So think about that and kind of give patients the balanced view. But in this case, I think that the fairly obvious conclusion is that we want to preserve accommodation. And so I don't think you would want to recommend doing a clear lens procedure at the time of DMEK. This is another patient who is 74 years old, and she was the one who recently came to me a few weeks ago, 3 weeks ago, and she was complaining of poor vision, driving, reading. You look at her exam, she has vision of 20/60 and 20/80. She has mild guttae, you can see them, as you can see on the specular. But overall, the cell count isn't too bad. You can see there's not a significant amount of polymegathism here. It looks overall okay. Her central pachy is 548, but she does have, significant lens changes. And so this patient was the one who I said, had some social issues. She lived alone. She was concerned about prolonged recovery. And so I said, yeah, if you think, a week or two is going to be difficult, especially when they have air bubble in, they may not be able to get around as well. And, in this case, the patient had the other eye, which she could have, fell back on, but she just didn't feel comfortable. So we had a long discussion and I said, look, I think, cataract surgery alone um, is an option and we can do it. I think that the chance of me making your cornea worse immediately is pretty low. I mean, I've done a lot of, DMEKs. I've done a lot of cataract surgery over the years now, and I feel pretty comfortable that I can probably, unless there's some unforeseen situations, end up with a patient who has really low impact on their endothelial cells, especially when they're already starting off with very mild changes like 548 and pretty good healthy endothelial cell reserve, as you saw. And so I tell them that, look, you may need DMEK in the future. We'll keep monitoring this. And I think if we get past the first, few weeks or month and the cornea does well, then I think the cornea is not going to be an immediate concern. And let's just do the cataract surgery, get you functioning a little better. This patient's vision was 20/60, 20/80. If I get her to even 20/30, with a little glare from the mild few guttae that she has, I think she'd be much more functional and she'd probably be happy with that. And so we gave her the option. I said, I'm happy to do both. I think you do have a little bit of, cornea issues, but I think here the primary consideration for me was cataract. And so that's the discussion we had. And I haven't had a chance to do her surgery yet, but I feel pretty comfortable with that discussion. And then, of course, there's this obvious case, where combined surgery is, obviously needed. You see patients with moderate edema, all the symptoms of Fuchs, they have blurred vision in the morning and gets better as the day goes on. You can see that they've got 2 to 3 plus nuclear cataract. So now I think that here the obvious solution is to do both combined. A not relevant really as far as healthcare is concerned, or as far as our practice is concerned, but when you do combined surgery, we definitely don't get paid for the second operation, 100%. And so there is that financial thing to think about. Obviously, we're not making decisions based on finances, but more importantly, what's in the best interest of the patient. But that's something to think about too, is that you do have the situation where you will not get paid the same as if you did the two procedures separately. But I think that has to be outweighed by what's right for the patient. Now, if we decide that this is the best thing for the patient, there are a few things that I think we can do to help make sure that we can get good results. And I'm going to just kind of talk about a few of these. And then in the last probably 15 minutes that we have or so, I'm going to go through this surgical case that I had. And I'm going to show you kind of just some areas where I try to focus on things. I'll try to focus on some things as far as the DMEK as well. Pearls just for DMEK in case anybody out there is starting out in their DMEK career as well. So we can kind of use this time to discuss that. And then afterwards, we'll be happy to open up for questions based on any of the stuff that I've talked about or any of the stuff that you have questions on in corneal surgery. So one of the things you'll see me doing is I'll mark the paracentesis blade with ink before I make it. And I think that's really important, especially when you're starting out. And even at this point where I am in my career, where I've done a lot of these, you still sometimes have trouble finding kind of where that paracentesis was. And especially when things are kind of going south with the DMEK and you're not able to unfold it, sometimes the fewer things you have to think about, the better. One of the things that I also recommend a lot is to make a slightly smaller capsulorhexis. Now, when I do a regular surgery for cataract, I usually make my capsulorhexis around 5.5 millimeters so that it typically overlaps the optic of the intraocular lens. But here I might even go a little smaller. I might go to even 5 millimeters. And that's because when you have a little bit larger opening, that IOL will trampoline a little bit. It'll go up and down. The chamber will be a little more unstable. And especially when you're trying to make your maneuvers to unfold the graft, put air in, things like you can see a lot of times, especially if someone has weak zonules and things like that, you can have a situation where a lot of pressure and manipulation can create long-term issues. You might give them a perfectly clear cornea, but if they've got, now a zonular dehiscence and the IOL's tilted, that's not, where we want to go either. So try to pay attention to that kind of thing when you're when you're in there and you're doing it. I tend to use myostat, and sometimes one of my colleagues just told me the other day that, oh, they don't like to dilate the pupil for cataract surgery. They just kind of use a little intraocular, dilating agent so that it's easier to get the pupil constricted again. I'll tell you that, I think for me, the most important thing here is to make sure the cataract is removed carefully. I don't want a situation where the nucleus is dropped, because then now you're talking about a completely different procedure than you thought about here. So whatever it takes for you to get that cataract out safely, if it means dilating the heck out of that eye, do it. Get the cataract out safely. You can always, if you can't see well enough or something else, you can always come back and do the cornea later. But once you make a mistake in the cataract side of things, then it's difficult to kind of recover from that. So I typically use a combination of dilating agents, which is only tropicamide pre-op, not phenylephrine. And the reason I do that is because when I'm doing my cataract procedure, I'll use intracameral lidocaine epinephrine mixture. And if you've already used phenylephrine before, you've kind of already saturated most of those receptors. Adding more phenylephrine is not going to give you as much of an effect. So a lot of times we'll see when I just use tropicamide and then I use intraocular epinephrine, then I'm going to get a real nice pupil, but it also responds well to myostat or myocol when I'm ready to do my DMEK. So we'll talk about that. When we talk about intraocular lens power, we talked about the fact that some of these patients become a little bit hyperopic, and that's because now we understand that when you do your Descemet or Rexus, even if you don't add volume of tissue with DSEK, you're going to change that corneal curvature and it becomes a little steeper. So now your intraocular lens calculations are off by about half to 1 diopter. So I typically will aim for a target of minus 0.75 when I'm doing my IOL calculations. And generally, those patients have been relatively, in that range and generally happy with the outcomes. And I'll tell you as I'm doing this, but the last thing I'll share as a pearl is that I got so wrapped up in my first combined procedure, I will never forget it, that the patient had cataract surgery, and I think I probably forgot to evacuate all of the viscoelastic out of the eye behind the iris until, when I was doing my cornea. I jumped right into the cornea, and I did a beautiful DMEK. It came out perfectly, but of course, the patient had pupillary block or pupillary, or issues with the retained viscoelastic. Pressure was, sky high, 75 or 80, middle of the night kind of thing. Went to the emergency room, didn't call me, and then I found out about it at 4 a.m. I went into the ER. I'm burping the eye at their slit lamp, and I'm just getting goads of viscoelastic coming out. It was not a fun sight. So remember to fully evacuate your viscoelastic before you start your cornea. So let me kind of go through this procedure in the last few minutes that we have here. And I'm going to show you here. I've marked, you can see right here, I can show, whoa, sorry. Let me go back. You can see here that the paracentesis blade that I'm using has been marked with ink. You see those little droplets of ink. And as you make your mark, as you make your paracentesis, you can kind of get an idea of exactly where that is. No fumbling around, no looking for it. I typically don't remark it. I kind of just do it one time. You can see here, however, that this is the inferior portion here, or of the iris. This is superior, and I'm operating on the left eye. And I didn't make my paracentesis right here inferiorly at 6 o'clock because I'm making my PI there, my inferior PI. I'm using a combination here of the epinephrine lidocaine, and you can see here that the pupil before we start that isn't super dilated, but it'll get more dilated as I'm using the epi-sugarcane mixture, and then I'll add a little more viscoelastic in and get it to be fairly big for my cataract procedure. I'm not going to bore you with my cataract skills, but I can kind of fast forward a little bit to the highlights here. What we're trying to do, of course, is to try to get the lens out safely and securely. And here, sometimes I don't mind. Typically, my cataract is kind of a chop technique, and I'll use basically iris plane phacoemulsification. I won't put the prolapse the nucleus into the anterior chamber, but you could in this case. You definitely could, because you don't really care about the endothelium, as you're going to be replacing it very shortly. And so here we're getting the cataract out, and then I'm removing the cortex. So now once you have sorry about that. back here. Wow, come on. So here, so I'm removing the viscoelastic, or sorry, the cortex, and then here I'm putting in some viscoelastic to put the lens in. And as I implant the lens, now here is where I want to be very careful, very thorough in removing all the viscoelastic from posterior to the iris. And I think that's what I forgot to do the one time. I kind of just, hey, give me some Mycol, let's go, and we're done. And yeah, I could complete the case faster, but believe me, it was a big hassle for the patient and for myself for that 24 hours afterwards. So be really extra careful, remove all the viscoelastic that you can. And so now the way I proceed here is, again, I'm just being extra careful, getting all of the dispersive viscoelastic from the anterior chamber. The other reason to do this is that if there's any retained viscoelastic in the anterior chamber when you're doing your graft insertion, that's going to interfere with graft unfolding, graft adherence, everything. So here I'm putting a little bit of Myocol or Myostat, whatever we have at the time. And you'll see that as I'm kind of preparing and as I'm performing my Descemet or Rexus, the pupil's going to come down very nicely. And even if it doesn't, I don't think that's a deal breaker. Now, try to avoid what I just did here. You don't want to get a lot of air bubbles in there because when you're inserting your graft, any little bit of air bubble is going to be a hindrance in terms of your ability to unfold the graft. The bubble acts as a barrier and you can't get past that. So that's something that you want to remove. But anyway, so here, I don't care right now because I'm putting in a little viscoelastic anyway. And what I've done is put in just the briefest amount of or the most minimal amount of viscoelastic that you can. And now I'm doing my Descemet or Rexus. And I like to operate where I'm making the least amount of hacking on the cornea. And I kind of make one semicircular, maybe two semicircular passes on the same side. And then I go to the other side and I do the same thing. I try to just complete it through one paracentesis, but you can definitely do it through two paracentesis. That's why you have them. Most of these patients who have mild to moderate fuchs are going to have a very easy capsular rexus or Descemet or Rexus. And you can see here now I'm kind of getting just the sub-incisional part over here on this side with my other paracentesis, and then I'm kind of reflecting the Descemet's membrane. Then I'm going to use a little scraper that will just kind of peel the Descemet's membrane out of the eye. And you can see here now that the pupils come down quite nicely. And I think that's really not so bad. And I think that when you want to do an inferior PI, it obviously helps to have a smaller pupil, but you don't necessarily have to. I think, just kind of be, careful about how you manage your iridotomy. But otherwise, having a dilated pupil doesn't really, change things too much for us. So I'm making sure that, all the tags of Descemet's are removed. And once I feel pretty comfortable with that, now I'm going to, while there's still viscoelastic in the eye, I'm going to make my inferior iridotomy. I typically like to use a vitrector handheld probe and just on a setting of IA cut, I'm going to get a little aspiration and I'm going to get the iris incarcerated into the vitreous or the vitrector. And then I'm going to just do a slight little pulse. The cut rate's about 2,000. So all I need is like a millisecond of cutting with the vitrector. And you can control the size of that iridotomy pretty well. You don't want an iridotomy that's too small because you're going to end up with potential for pupillary block. And you don't want one that's too big because then it doesn't look really nice and patients don't get glare and things like that. So that's about a good size there where I would say you're going to be fine. Now here I'm removing all the residual cohesive viscoelastic that I put in there, and I'm making sure that all the air bubbles are gone and all the viscoelastic is gone. I'm a little bit anal retentive about things, so I kind of make sure that I use extra, and you can see here, you see these folds in the capsule. You can kind of see how this is going to become potentially an issue when you're doing a DMEK portion where there's going to be a little bit more trampolining. And that's the advantage of having a separate procedure, because now you've had this time for the cataract, the lens implant to be kind of more stable. The iris diaphragm, along with the IOL diaphragm, is more stable. The capsule is more rigid. It's just easier. But we're gonna muddle through here. So I end up then removing my viscoelastic carefully. here's the part where I'm getting the graft. And what I love about what Eversight's done, and I encourage you all to do this, is to use their preloaded tissue that comes in the DORC tube, the Dutch Ophthalmic Research Corporation tube, and it's like one stop. You basically pull it out of the container and you inject it, and it's so simple. There's no tubing, there's no trampolining of the chamber. You can see how here, I'll rewind this a minute. You can see how the chamber stays completely stable. There's a 2.4 millimeter incision. This is the DORC tube, which is thin and long. It goes in right through that tunnel very nicely. I go past the iris, past the pupil, and inject. You can see there's no shallowing of the chamber. There's no tendency for the iris to come out of the incision. I used kind of counter pressure as I'm pulling out here on the cornea with my forceps, just because you can have a situation sometimes where the graft wants to retract, back out of the eye. And then I do use a suture. I think there's a way to do this with just hydration, but for me, I find it easier and a little more controlled if I'm just putting a suture in. So I will then put a little suture to kind of make sure that the graft is not going anywhere, and just tie that down and rotate it. Now here I'm doing my DMEK procedure, where you all hopefully are familiar with this. And this is really nice because I've got a situation here where the graft is already kind of unscrolled. It looks to me in a 3D fashion that it's in the right configuration with the scrolls pointing upward. I also, of course, use the S stamp, and that's really been very helpful and beneficial to me. And here we can kind of see how we go about getting this to unfold. And so we're using different maneuvers. We're using, a little bit of flattening of the anterior chamber. Again, I'm releasing a little bit of fluid through the main incision right here. And as I'm flattening the chamber, the graft wants to automatically already unfold. Now, I'm making sure that my S stamp is right side up. And as you can clearly tell, it is not, right? So as we unfold it, as you can see, pay attention to this, you can see that this S is backwards. And so I'm flipping it. How do I flip it? Well, I'm going to take little bursts of fluid through the paracentesis with BSS, and I'm just giving it a little burst, and it'll kind of flip. I'm flattening it out again, and this time I'm going to check it and make sure it's doing what it did. So the reason I like the S stamp is that there are times where you think, oh, this is definitely right side up, but it may not be. And sometimes it's an illusion. Sometimes maybe the graft is folding in a different way too. And the way that you know that is because the stamp was done, when you had the S stamp, they know it's on the stroma. So you're absolutely 100% certain, and that's what I'm going by. And I just feel like that's, for me, the best indicators to have that S stamp. So you can see now here that the stamp is in the right configuration. I'll just show you that flip maneuver again one last time so you can see here that the stamp is it's backwards. The graft is upside down, and I'm just using a little bit of burst of fluid just to kind of just flip it over. Right there, it's still backwards. And I don't know if you can see it, I should slow this down sometime, but you can kind of just see it there, that it just sort of, boom, right there. It just kind of twisted all the way over, and now it's straight. And you can confirm that as you're unfolding it, that you have an S stamp. So when you flatten the chamber, you get good opening of the graft. Here I'm using the Descemet 2 cannula technique, where one cannula in my left hand, typically this one will hold the graft down, and the other one will kind of tap, and you're using the fluidics of the anterior chamber, the aqueous, to just unfold the lens. And here I'm using a little flattening maneuver because I think there's still some more fluid in there. And then I'm just tapping on the eye, tapping. This one doesn't want to go very smoothly, but it'll get there. Just be patient and it'll work. I like this 2 cannula technique because it really kind of holds the graft in position, and you can use it to sometimes just really stretch that out there and really flatten it out. And here you can see we're making progress, and all these maneuvers are on the corneal surface. Obviously, nothing's intraocular. And so now here I find that, well, now in all this maneuver, my graft got decentered a little bit. So you can use kind of some tapping maneuvers. Again, all you're using is the fluidics inside the eye, the current of the aqueous to kind of push things where it needs to be. And I'm pretty happy with that configuration there. And so now I'm going to use my gas bubble, and I use SF6 gas. I try to go in where there's a clear opening. Sometimes if the graft is too big, you'll be stuck up against here. And as you enter in, you're going to fold the graft. So try to find a place where it's not um, covering the para. In this case, I could have gone in here or here. Sometimes if the graft is more to one side, you can use the other side to get under. And you can see the cannula is turning blue, so I know I'm under the graft. Careful not to kind of go onto the endothelium, but you don't want to inject on top. Otherwise, you'll have to remove all the air and kind of go back to square one again. So here it's underneath, and I'm getting a nice, firm fill, and I am pretty much, done with this procedure. So I just had an interesting case today I'll tell you about, or yesterday, where I did a procedure, and I see these patients back in the office a couple hours after the procedure to just check on their pressure. And this lady had a pressure already of 70 yesterday, and I removed a little bit of the gas, got the bubble down to about 80%. The bubble was above the inferior PI. She felt comfortable. Her pressure was back down in the 20s, and I sent her home. Well, then 2 o'clock in the morning, she called again saying, I'm in a lot of pain. And she had completely filled up again. The bubble was 100% again. So I think it's really important to make sure that when your staff in the OR is diluting SF6, if you're using SF6, to make sure that you're using the right concentration, a non-expansile concentration. I used to use 20%. Now I'm using 15%. It probably lasts a little bit less longer, but you may get potential issues. And I know yesterday I had a new scrub nurse, and I think that, there might have been an issue where the pressure, went up because the concentration of the gas was just too high. But keep that in mind as you're doing this procedure, that those are things to kind of watch for. But this is a great case. This patient ended up doing really, really well. Triple procedure, and refractive surprises can be a thing of the past if you kind of pay attention to all of these different things that we've talked about, and all these little steps and tips and pearls and pitfalls kind of throughout the process. So I'd like to open up here now for questions. Again, this webinar is being recorded, so you can review this anytime you want to at eversightvision.org/webinars. But thank you very much for your attention. I'll be here for a little bit longer. Let's see if there's any questions that have come up, and be happy to address those.
And as we noted earlier, if you do have a question, you can type it in the Q&A panel at the bottom of your screen, and we'll respond. We do have one question, Dr. Majmudar, from Michael Seward. What percentage of your DMEKs are triples?
Good question. I don't know the answer to that. I'd probably say close to 50-50, but probably err more on the side of triples these days than DMEK alone for various reasons. Maybe 60-40.
Okay.
A lot of times it depends on kind of what your referral patterns are. You may work with a cataract surgeon who is a good referral source for you, and a lot of times I'll say, hey, you do the cataract, because the cornea is not too bad, and we'll do the cataract cornea if we need to. And a lot of times that would kind of determine kind of what your percentage is of triples versus DMEK alone. And a lot of times you may have a situation where the referring doc will say, look, this cornea is pretty bad. I don't think I can see well enough. I don't really care that much. Go ahead and do both at the same time. It's better for the patient, whatever. And so that may affect your percentages as
well. Okay, we have a comment and question from Robert Fantis. Thank you for the great talk. What OVD do you use for the phaco and DMEK?
So my center uses Alcon products. So I use Viscoat for the cataract portion, which is the dispersive viscoelastic. It's kind of habit probably because we, want to protect the endothelium in a normal cataract, but in this case it's not as important. But I do think you get a little bit more, space maintenance with Viscoat. And so I do my cataract with that, but I'm very careful to remove it all, as you saw, before I proceed with DMEK. And then for the second part of my cataract operation, I guess it's called DuoVisc. So the first part is Viscoat, which is the dispersive, and then the cohesive is called ProVisc. So I will use ProVisc for intraocular lens implantation, as well as for creating a little space for the Descemet rexus. I don't want any dispersive viscoelastic in there. If I'm doing DMEK alone, I will only use ProVisc, which is the cohesive, again, because I don't need a lot of space. All I want is a little bit of space to do the Descemet rexus. When we have, we're starting out doing Descemet rexus, when I learned to do it, in Rotterdam with Melis's group, they do all of their Descemet rectus under air, which is great for visualization, but it is very, very challenging because the chamber just keeps collapsing. And so I use a little bit of viscoelastic, but it's typically going to be the cohesive, so it comes out very easily. And I don't use a lot. I try to use a minimal amount.
Okay, I'm going to give it one more minute in case there's any other questions. Again, you can type them into the Q&A panel. Dr. Jung Lee has a question. What is your standard DMEK graft tissue size with triples, and how large is your descemetrexis?
Yeah, great question. So, when I started out, again, the Rotterdam group, Melis's group, they were doing 9.5 millimeter grafts, and they were going out. They would spend almost, an hour and a half, 2 hours a case, because they were actually in those days, they were going out all the way out, I'm sure, to Schwalbe's line. Basically, they were removing all of the Descemes if they could, and they were spending a lot of time doing that. And they would put a large graft in 9.5. Now, that has some advantages. You're getting a lot more endothelial cells into the eye, but technically it's very difficult unfolding. It's also very difficult, as I showed you earlier. My case didn't have that, but when you're trying to put gas in, if the graft is all the way out covering your paracentesis, it's going to be hard when you enter to put the gas or air in. You're going to probably hit the graft. You're probably going to create issues. And so I like my grafts to be smaller. I started out doing 8.5 millimeter grafts, and now I'm down to 8.0 millimeter grafts. And I think that's probably adequate. I know there's less endothelial cells than an 8.5 or 9.0 millimeter graft, but I think handling wise is very easy. I almost never have a problem getting the cannula in and creating issues. And I think for the most part, 8 millimeters is quite large enough that people do well. So I use that as my standard graft size on any procedure, whether it's a combined procedure or simple DMEK.
Okay, if there aren't any other questions, just going to give it one more minute. Okay, I don't see anything additional coming through, so I would like to thank everyone again for joining us today. This webinar has been recorded and will be available on the website to view on demand. A very special thank you to Dr. Majmudar for serving as today's speaker and for providing us with your invaluable expertise on this subject. I hope everyone has a wonderful evening. Thank you.
Thank you for the opportunity. Have a good night, everyone.
Thanks so much, Dr. Majmudar.
My pleasure.